Hello everyone, this is a preview on pediatric cardiology.
Chest pain in children and adolescents. Clinical case scenario. This is a 15-year-old adolescent boy is brought to you for evaluation of a chest pain. He had a chest pain 2 days ago during soccer game and had to leave the game. He describes the pain as dull and points to the middle of his chest. It was worse when he was running. This is very important. The pain resolved with rest and fluids. He denied rapid heartbeat sensation. No family history of sudden death or death under the age of 30 years. He denied using any illicit drugs. Physical examination is normal. EKG showed ST segment elevation from V1 through V6 with ST segment depression in the inferior leads. What is the most likely diagnosis? Musculoskeletal pain, precordial catch, anomalous coronary artery, or exercise-induced asthma? The correct answer here is anomalous coronary artery. The key point here that this adolescent has the pain when he was running during exertion. This is a red flag for cardiac chest pain. Non-cardiac chest pain is the most common cause of chest pain in pediatrics. Taking a detailed history and physical examination is the key, and this can establish the diagnosis of pain in most cases. Cardiac chest pain is rare. However, we have to explore and ask the proper questions to rule out any cardiac source of the chest pain. Precordial catch syndrome is a very common benign musculoskeletal chest pain in older children and young adults, presented with severe and sudden chest pain over the heart, over the left precordium. The child or adolescent will describe the pain as knife-like sharp pain. And during the episode, the child will look like he cannot catch or she cannot catch her breath. Especially deep breath will make the pain worse. The child has no limitation with exercise, no problem with physical activities. The pain classically lasts for 30 seconds to 1 minute. Physical examination is typically normal, the cause is unknown, and the management is reassurance. No investigations are required whatsoever. Red flags for cardiac chest pain. Ask for pain with exertion, pain with exercise, pain during swimming, syncope or collapse during exercise or while swimming, fatigue, shortness of breath with exertion or activities, pain preceded by tachycardia like cases of supraventricular tachycardia, family history of heritable conditions such as hypertrophic cardiomyopathy. Non-cardiac chest pain, musculoskeletal pain is very common. The adolescent will describe as pain or tenderness when they apply pressure on the chest. Asthma. Ask about family history of asthma. Eczema. Ask about history of using inhalers or nebulizers in the past. Coughing after or during exercise. Pneumonia, as in this case, you see pneumonia in the lung can cause a chest pain and anxiety. Recent major stressful events like separation from friends, family, divorce. Reflux. Ask about the pain during meals or after meals or meal related. Sickle cell diseases, vaso-occlusive crisis, or acute chest syndrome. This is a 13-year-old female while standing and waiting for her turn in school during lunch. She felt lightheaded, weak, nauseous, and passed out for 5 seconds. She looked pale and had cold sweat. Her friends called her and helped her to lay down, and she felt better after. She has no history of seizure, no other medical problem. Her physical examination is normal. What is the best course of action? EKG, echocardiogram, stress test, or reassurance? The correct answer here is reassurance. The key point here that she passed out while standing, while staying still, not in motion. This is vasovagal syncope, very common, very benign. Syncope. Syncope is a temporary loss of consciousness, maybe due to generalized cerebral hypoperfusion or neurologic disorders. The most common form or most common cause in pediatrics is vasovagal. It is an exaggerated reflex in vasomotor tone and heart rate, causing vasodilation, hypotension, and bradycardia. Causes of syncope vasovagal. This is the most common, which is impaired response of the autonomic nervous system. This is the most common form of syncope in pediatrics. Classic cases of vasovagal syncope require only reassurance. No investigations are required. Initial evaluation of a suspected cardiac cause, order electrocardiography. Look at the rhythm. Look for left or right ventricular hypertrophy. Further evaluation if the diagnosis is still not clear. Order 24 Holter monitor or 30-day event monitoring if you suspect tachyarrhythmia. Echocardiogram is indicative of abnormal physical examination or abnormal electrocardiogram. Cardiac arrhythmias or electrocardiography can be abbreviated as ECG or AKG. This is a 12 leads ECG 10 seconds recording. We have large squares and small squares. Each small square equal 1 millimeter by 1 millimeter in size. Each large square has 5 small squares by 5 small squares, or 5 millimeters by 5 millimeters. Very important to look at the calibration. Standard calibration is 2 large squares for the amplitude. 2 large squares for the amplitude, or 10 millimeters. The standard speed is 25 millimeters per second. In this case, each small square equal 0.04 seconds or 40 milliseconds, and each large square equal 0.2 seconds or 200 milliseconds. In this case, 5 large squares will be equal 1 second. If 1 second equal 5 large squares, this means 60 seconds equal 300 large squares, or 1 minute equal 300 large squares. If we take one cardiac cycle from here and we look at it, we have wave, we have segment, we have complex, and intervals. So wave means deflection. If the deflection is above the baseline is positive, if it's below the baseline is negative. Then we have segment, which is a portion of the baseline, and the interval means a wave plus segment, and complex means multiple waves without segments. P wave represents atrial depolarization. PR interval represents atrioventricular conduction, and the QRS complex represents ventricular depolarization. ST segment and T wave represent ventricular repolarization. The QT interval from the beginning of the Q to the end of the T means the duration of ventricular depolarization and ventricular repolarization. When we look at the ECG, we have 12 leads ECG, and we look at the rhythm leads in the bottom. The rhythm leads in the bottom to look at the rhythm and rate. Then you have here the 12 leads. You have lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. Lead 1, AVL, and V5 and 6, they are well known as lateral leads, and they look at the electrical activity of the lateral wall of the left ventricle. Then you have 2, 3, and EVF, well known as inferior leads. Inferior leads, they look at the electrical activity of the inferior surface of the heart. Then you have septal leads V1 and V2, and V3 and V4, well known as anterior leads, and they look at the electrical activity of the anterior wall of the right and left ventricle. V1 and V2, they are a great window for the right ventricles. V5 and V6, they are great windows for the left ventricle. Then when you look at the ECG, you start to analyze the waves, and we need to be familiar with the variation of waves in different leads, and also variation of waves according to the age. So if we start here, PQRST, 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 you see here the P wave is positive in lead 1 but is negative in AVR. This is normal. So if you look at here, also the T wave is positive in lead 1 but is negative in AVR and V1. This is also normal. But T wave can be positive normally in newborn less than 7 days or less than 1 week of age. Afterward, if it stays positive, this is suggestive of right ventricular enlargement, just suggestive, but can be normal in older children, like older than 6 to 7 years of age. Then we need to look at the QRS ratio and variation according to the age. This ECG is for 8 years old. If this is a newborn, you will see the R wave here in V1 is larger than that, and the S is smaller than that. As the infant and children, they grow, the R wave keep declining, keep getting smaller in V1, and the S keep getting deeper, and the opposite occurs in V6. So this is also a variation. Very important also to know that the QRS ratio in V1 is different than the QRS ratio in V2 and V3. So this is very important to consider before start reading an ECG. Very important to have a systematic approach when you are reading electrocardiogram in order not to miss any important information. Step 1, you look at the rhythm, rate, and the axis. Step 2, to look at the P wave, PR interval. Step 3, QRS complex.
Then step 4, you look at the QT interval, ST segment, and finally T wave.
This is a 6-year-old presented with difficulty breathing, then collapsed. What is the most likely diagnosis? If you look at the EKG here, you have tachycardia. Tachycardia, you see the QRS complex is wide and bizarre. QRS complex and tachycardia. What is the most likely diagnosis? Atrial flutter, atrial fibrillation, ventricular tachycardia, ventricular fibrillation. The correct answer is ventricular tachycardia.
Ventricular tachycardia, definition of ventricular tachycardia in children is defined as tachycardia of at least 3 successive ventricular beats. A ventricular, when we say ventricular, means that the QRS will be wide and bizarre. Wide complex, not narrow complex. If it's narrow complex, it will be supraventricular, not ventricular. Ventricular when the complex is wide, and we'll see it in the example. Causative factors include drugs, caffeine, decongestant. So be careful about prescribing decongestant, especially to very young children. Be careful with the dose. Electrolyte imbalance, underlying cardiac disease, prior cardiac surgery, and cardiomyopathy.
We'll start a new section, heart murmurs. In this slide, we'll classify the murmur according to the source. If the source is from the aortic valve or pulmonary valve, if the lesion is stenosis or the pathology is stenosis, will give you systolic murmur. If it's regurgitation, will give you diastolic murmur. If the source of the murmur is mitral valve or tricuspid valve, if it's stenosis, will give you diastolic murmur. If it's regurgitation, will give you systolic murmur. Step 1 in listening to the heart, auscultate while the patient is supine. Step 2, auscultate while the patient is sitting. Finally, auscultate the back. When you check for murmur, check the loudness of the murmur. We grade it from grade 1 to grade 6. Grade 6 is the highest, grade 1 is the lowest. Timing of the murmur, systolic or diastolic. Location of the murmur will help you to identify the source of the murmur. Radiation of the murmur and pitch of the murmur. Innocent murmurs are typically quiet, grade 1 or 2. Systolic, located over left sternal border, possibly radiate to left or right sternal border. Low-pitched, vibratory or musical, decrease in intensity from supine to sitting position. This is a child coming for routine physical exam. In your examination, you find or you heard ejection systolic murmur with a vibratory character. Best heard on the lower sternal border towards the apex. What is the most likely diagnosis? Still's murmur, venous hum, VSD, or ASD? The correct answer is Still's murmur. Again, to emphasize on Still's murmur or innocent murmur, because it's extremely common in pediatrics, and this type of murmur require only reassurance. No echo, cardiogram, no referral to a cardiologist because of this murmur. It's very benign. It is non-radiating, early systolic ejection murmur, low intensity between 1 to 2/6, short duration, located at the left lower sternal border, vibratory or musical quality. I will give you a few seconds to listen to this murmur. Another common innocent murmur in newborn, peripheral pulmonary artery stenosis of the newborn. The murmur is related to the take-off angle of the branch of pulmonary arteries in the newborn. Characteristics of this murmur, systolic ejection murmur of low intensity, best heard at the left upper sternal border and radiates bilaterally to the axilla and the back. Remember, the innocent murmur or Still's murmur doesn't radiate, but this murmur radiates to the axilla and the back. Louder actually in the axilla or the back than the anterior chest. A split second heart sound of normal intensity. This murmur is benign and disappears by 3 to 6 months. This is a 6-year-old with systolic diastolic murmur, low-pitched sound, best heard in the infraclavicular region, disappears when supine and with gentle pressure on the jugular vein. What is the most likely diagnosis? Still's murmur, venous hum, VSD, ASD. The correct answer is venous hum. This is a 2-month-old infant with respiratory rate 80 breaths per minute. Blood pressure is 90/60 millimeter of mercury. Heart rate is 170 beats per minute. And the oxygen saturation is 90% on room air. On physical examination, the infant has no stridor, no wheezing, or other adventitious sounds. Mild, he has mild intercostal retractions. Cardiac examination reveals regular rate and rhythm, but you have systolic murmur. Holosystolic murmur, 3/6. Holosystolic murmur or pansystolic murmur, best heard on the left mid-sternal border and throughout the precordium. The liver edge is palpable and is about 4 cm below the right costal margin. What is the best next step in the management of this infant's condition? A. Lisinopril, furosemide, calcium channel blockers, or digitalis. The correct answer here is furosemide. This infant is suffering from congestive heart failure and pulmonary edema secondary to ventricular septal defect. The key words here, respiratory distress, low oxygen saturation, and holosystolic murmur because of VSD, and palpable liver edge secondary to congestive heart failure. The best management in this case, or the first step, is to give furosemide to relieve the pulmonary edema or to decrease the edema in the lung. We'll classify here cyanotic congenital heart defect according to the appearance of chest X-ray. If associated with increased pulmonary vascularity, the example of that simple transposition of great arteries, total anomalous of pulmonary venous return, or truncus arteriosus. If around the heart is dark, very dark, this is decreased pulmonary vascularity. And the example of that tetralogy fellow, tricuspid valve anomalies, for example, tricuspid atresia, Ebstein anomalies, or pulmonary atresia. Of course, if you have prolonged left-to-right shunt in cases of acyanotic congenital heart defect, for example, VSD, this can cause pulmonary hypertension, Eisenmenger syndrome, and cyanosis. This is a chest radiograph for a neonate who presented with severe cyanosis. If you look at the chest radiograph, you will see the heart here is big. There is a cardiomegaly associated with decreased pulmonary vascular markings in both sides. This indicates cyanotic heart defect with right to left shunt. There is a simple test you are able to differentiate between cardiac and non-cardiac causes of cyanosis, hyperoxia test. Supplement the neonate with 100% oxygen. If it is non-cardiac, you will see the partial pressure oxygen saturation is more than 100, more than or equal 100, and you will see the cyanosis will improve while the neonate on 100% oxygen. This is lung, this is pulmonary, not the heart. If it is cardiac, the partial pressure of oxygen in the arterial blood will remain below 100. This indicates cardiac or congenital cardiac defect cyanotic type. Cyanotic heart defect in details. 2 months old presents with cyanosis, poor feeding and crying. There is a palpable right ventricular impulse, single second heart sound, harsh systolic ejection murmur over the pulmonary area in this location, left sternal border. EKG shows right axis deviation, right ventricular hypertrophy. Chest X-ray showed boot-shaped heart and dark lung, decreased pulmonary vascularity. What is the most likely diagnosis? Tricuspid atresia, transposition of great vessels, tetralogy fellow, aortic stenosis. This is a classic presentation of tetralogy fellow. The famous 4 criteria for tetralogy fellow, tetra means 4, perimembranous ventricular septal defect, pulmonary stenosis, overriding aorta, right ventricular hypertrophy. Another case scenario, there is a child with tetralogy fellow. He is crying, has worsening cyanosis, progressive oxygen desaturation, and tachypnea. What is the best next step? Knee chest position, digitalis, consult the pediatric cardiologist, or echocardiogram. Best next step is knee chest position. This is a high yield. If you have a child with history of tetralogy fellow suffering from hypercyanotic spill, the best next step is knee chest position. Then administer oxygen with calming measures, placement of an intravenous line to give a bolus of fluids, administration of morphine, either IM or sub-Q, sodium bicarb, phenylephrine, and beta blocker, for example, esmolol.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you. Presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams!